Good morning and welcome. My name is Larry Kokot, and I'm Senior Counsel at the Engelberg Center and a visiting fellow in the Economic Studies Department at the Brookings Institution. It's my pleasure to welcome you to this important event this morning that will focus on the question, can forces align to use health IT to improve care and lower costs? Now, if you look at where we are, no one can deny that we've made rapid progress in the adoption of health IT tools and strategies since the inception of the High-Tech Act of 2009. As you can see, by dedicating roughly $27 billion to eligible providers who demonstrate meaningful use of HIT, by 2013, 48% of physicians and 59% of hospitals had adopted basic EHRs. That said, there are many challenges still ahead for us in order to realize the promise of true and meaningful interoperability of health information to move the needle on improving care and lowering costs. A recent article by some RAND researchers points out that the existing knowledge base for the value of HIT is not advancing as fast as the adoption of HIT. But we certainly have seen outcomes that highlight components of the value of HIT. For example, increased electronic distribution of patient discharge information among providers has helped to reduce hospital readmissions. Also, EHR protocols and alerts have contributed to the reduction of medical errors in hospitals. And additionally, electronic data sharing has also improved care coordination and quality, particularly in the context of our accountable care organizations, which we spend a lot of time on here at the Brookings Institution. Now, Secretary Burwell's recent announcement to rapidly increase value-based payment models through value-based payments through alternative payment models will create even more demand for more effective health IT. In fact, electronic data sharing and meaningful interoperability are foundational to the continued development and success of alternative payment models. As you can see here, this slide illustrates that 8 in 10 physicians participating in delivery form activities are using electronic health records, most of whom are also using those records that do meet the requirements of meaningful use criteria. But this really illustrates the reliance on physicians will have on value-based models, how much they will place on HIT in order to participate in these value-based models. But again, going back to the challenges, they're formidable, and we must overcome them to optimize the use of health IT and to get to real interoperability of systems and data in healthcare. As of last month, only 24% of physicians had attested to meaningful use. Most health IT tools don't support the information needs of clinicians in the way they need it. Dissatisfaction with the usefulness and usability of current health IT tools is common among providers. Patients and physicians alike lack access to transparent, accurate, actionable data across the care continuum, particularly on cost and coverage. And let's face it, true interoperability has not been achieved yet. What does this mean to for health IT moving forward? In this conference, we hope to answer these questions on the screen behind me. So today's event is about progressing to a health IT environment that allows providers to do what needs to be done to support them in giving better care to achieve the best possible health outcomes for their patients. Much of the focus today will be on framing health IT policy to better enable providers to give high-quality care that leads to better health outcomes for their patients. Our discussion today will begin with Dr. Peter Bash. Dr. Bash will open the conference with by offering some introductory remarks on the promise of health IT. Peter will then introduce the first panel, which we have here. Peter will then introduce the first panel for a discussion on successes, failures, and continuing challenges with the implementation of health IT. Following that panel, we're going to move to a panel a very exciting panel that Mark McClellan will be chairing with two very distinguished former coordinators of health IT. We're going to do a short break after that and come back for a keynote for the current coordinator for health IT, Karen DeSalvo. And then finally, but certainly not least, we are going to a final panel on what is needed from policymakers, technology developers, and providers to support high-value health care. Now, just a few housekeeping matters before we start. We really appreciate you taking the time and effort to join us today, particularly as the impending storms are here in Washington. It seems like when it rains, it's an event here, but nonetheless, we do appreciate you getting here. Hope you can get away in time from Washington if you came just for the day. As a reminder, today's event is being webcast live. To ensure the audio quality of the recording, we'd like to remind you to turn your cell phones on silent so that you don't disturb the speakers or the communication. We'll have time for some questions and comments at the end of each panel. So we'll have microphones available for your use. They'll be traveling around. Just raise your hand and we'll get them to you. This event's being recorded and supporting materials will be available soon on the web. So let's get started. It's a privilege to introduce Dr. Peter Bash. He's Medical Director for EHR and HIT Policy at MedStar and also a visiting scholar here at the Engelberg Center at Brookings. Delighted to have Peter kick this off for us. Peter, welcome.
Thank you, Larry, and good morning, everyone. Can forces align to use health IT to improve care and lower costs? This is a question that is only recently possible to pose to anyone who is not a health IT futurist. Rather than seeing this as a question necessitated by divisiveness, I believe it is a very natural question to pose whenever something that was previously hypothetical evolves to be mainstream, and mainstream it is. It is truly a stunning accomplishment that in slightly more than a decade, the majority of doctors and hospitals are now using EHRs and other health IT, and electronic prescribing is now the predominant vehicle for creating and transporting prescriptions. And this technology revolution has been accompanied by a cultural shift within the field of medicine, a shift that now expresses the thought that not only do patients and families deserve timely access to their health information, but also how can we as health professionals expect health and healthcare to improve without engaged patients and families as full partners in collaborative care. Raising the question of aligning forces is thus a tribute to the bipartisan vision and leadership that has brought us to this day. So let me get into the meat of my comments. Can health IT enable high-value care? First, let me explain what I mean by high value. To me, high-value care is care that is evidence-based or evidence-informed, achieves desired outcomes, and is at least attentive to cost. Can health IT enable this? Yes, without question. Has this occurred, more importantly, has health IT consistently enabled high-value care in such a way that any end user can purchase and install a system and see similar results? Obviously, no. We've all heard the expression, results may vary, but I'm not implying that health IT is like a medication and each individual's metabolism or genetic expression varies a response such that the response is unpredictable. To the contrary, enough is known about health IT such that we could and should know what is necessary to have it consistently enable better care. First, health IT is not magic. It is at best enabling infrastructure. Health IT can bring informational displays of relevant patient characteristics, due or overdue care opportunities and unmet goals, prior results and treatments, patient preferences, information from other providers, and help to present all of this into an efficient package of educational material, alerts, and reminders. And clearly, at least for clinicians for whom managing complex information is critical, health IT can reliably and consistently enable high-value care. So why doesn't this happen all the time? Because health IT is necessary but not sufficient to alone improve quality and value. Todd Park, the second U.S. Chief Technology Officer, and I wrote about this in 2009 when we described how the existing fee-for-service provider payment system created a business case for health IT inertia, where EHRs would be used for nothing more innovative than documentation guidance, and workflow would remain limited to reactive office visits. We envisioned that the soon-to-be-announced Meaningful Use program would serve as a status quo disruptor, where technology and workflow incentivized in the short term with dollars for EHR adoption and more meaningful use would be elevated to a more virtuous cycle of ongoing innovation in technology and workflow, with the fuel for this cycle coming from an anticipated shift in provider payment, one more aligned with quality and value. And with the recent announcement from CMS that it's accelerating its shift to value-based payment systems over the next 3 years, one could conclude that the stage has been set and we are now on a glide path for health IT and workflow optimization in support of and supported by this new approach to provider payment. One could conclude that, but I wouldn't. While there are many exceedingly talented people, some of whom are with us today, who have been able to demonstrate success with existing technology, I would suggest that their success additionally reflects their vision, leadership, and dogged persistence. So without taking anything away from their accomplishments, I would suggest that the promise of health IT has not been kept and that the return on the substantial public investment has not yet occurred until the benefits of health IT-enabled care are available to all Americans. How to get there, then? That is the most important permutation of my topic question, which is, will health IT and provider workflows be broadly available such that most Americans will experience higher value care by 2018 or shortly thereafter? And that is a definite perhaps. What needs to happen such that in most instances perhaps can be replaced with probably, or even better, almost certainly? We believe that attention and resolution of a relatively small number of issues can make that difference. These issues are discussed in the first installment of our upcoming policy brief, Progressing Beyond Meaningful Use, which was published yesterday in the Brookings Health 360 blog, and will also be discussed by our esteemed panelists this morning. As we seek to align forces such that health IT can support better care and lower costs, we are posing the question of how best to effect that change. Does existing policy need to be amended? Are new policies necessary? Or are we on the right trajectory and what is needed is just patience? A few words on what most people think about when they ponder the question of why health IT is not yet consistently improving care. The lack of interoperability. Being able to securely and effectively exchange information from labs, between providers, between settings of care, between providers and patients, clearly adds value. And the current high cost of clinical interoperability needs to continue to be addressed. Where we differ from others on interoperability, we do not believe that simply fixing interoperability will in and of itself lead to high-value care. What else is problematic then and needs to be addressed? Usability is one. While there are existing efforts on inserting a design principle called user-centered design, we are concerned that that is also not enough. There is reasonable evidence that meaningful use, through its reliance on defined process measures that also define certification requirements, has made at least some workflows non-intuitive. And as the Meaningful Use program has the same process measures for all providers and all specialties, by and large, what every provider experiences is more or less the same. We believe that the growth of value-based payment methodologies may obviate the need for most, if not all, process measures, which should have the intended consequence of allowing EHRs to become more flexible and work more effectively for providers in all specialties. This is important because in the near future, we will be asking providers to do more, pay even closer attention to quality and cost. Hard to do as long as your EHR feels less like a finely oiled machine and more like the children's game of Twister, which requires you to be a contortionist to do well. And speaking of controlling costs, how exactly will that occur? Currently, there is next to no cost and health insurance coverage information available to patients and providers when it might actually be useful in an electronic format before and at the point of care. Generally, information is made available only with the metaphorical touching of a third rail, an annoying and wasteful approach, as it almost always requires rework for the provider and delay to the patient in necessary testing or treatment. Health IT policy has been inexplicably silent on this issue to date. So in addition to making it easier and less expensive to get clinical information imported and exported from EHRs, we are calling for a new policy to get cost and coverage information into electronic health records and other health IT. The timely availability of transparent, accurate, understandable, and actionable cost and coverage information is not only necessary to have a chance at thoughtfully managing costs, it's the right thing to do. And another intended consequence of this approach, many prior authorizations, the bane of many providers' existence, could be avoided by substituting covered and preferred alternative testing and treatments, thus making EHRs useful by reducing practice operational burden. In summary, leveraging the shift in provider payment permits health IT design and use to move from prescriptive process measures to being more closely aligned with the achievement of higher quality and value. With mandated and flexibility out of the way, user-centered design efforts can be more effective, and with the inclusion of necessary cost and coverage information, along with incremental improvements in clinical information exchange, we will have the necessary ingredients such that forces should align and health IT can fulfill its promise of enabling high-value care. Thank you. And now to our first panel, and if our first panel could come up and take their seats, please. On our first panel, which will be a report from the front lines of health IT, transformation, barriers, challenges, and successes, we have Mark Bennett, the President and CEO of Health Insight. Health Insight's work with providers on health IT adoption and meaningful use includes work as an ONC Beacon community, a regional extension center, a Medicare QIO, and a host organization for a statewide HIE in Nevada. Mr. Bennett also chairs the board of Utah Health Information Network. He is currently vice chair of the board of the Network for Regional Health Improvement and serves on the executive committee of the Center for Healthcare Transparency. John Blair, the CEO of MedAllies and the president of Taconic IPA. Taconic has been working over the past decade on community-wide transformation across all healthcare stakeholder groups. Currently, they are achieving several aspects of an IDN in an open community. They have leveraged meaningful use with over 90% of providers on certified electronic health records and have some of the highest NCQA Level 3 patient-centered medical home levels in the country. They're one of the 7 CPC regions with promising early results on cost savings. Third, we have Mark Siegel, the Vice President of Government and Industry Affairs for GE Healthcare IT. Mark is very active in many public and private sector organizations focused on health IT policy issues. He has been very engaged in the implementation of the EHR incentive program within GE and externally, as well as in thinking about how health IT and health IT policy can enable new delivery and payment models. Mark has a BA in political science and a PhD also in political science from MIT. And last but not least, Michael Zarukian, Vice President and Chief Medical Information Officer at Sparrow Health and a Professor of Medicine at Michigan State University. Mike is a practicing general internist and board-certified clinical informaticist with deep experience in EHR implementation, optimization, usability, and hands-on support of frontline physicians in EHR adoption and meaningful use. He currently serves on the HIMSS Board of Directors, the ONC Health IT Policy Committee on Advanced Health Models and Meaningful Use Work Group, and the AMIA EHR 2020 Task Force. So welcome, panelists. Thank you for coming. Let me start this off with the first question to Mike. Mike, you have written and spoken extensively on the importance of health IT usability. One of the key points in our policy brief is the assertion that an EHR cannot reliably and effectively enable value when the EHR is not highly usable and useful. I guess this is a two-part question, and you're welcome to make it a 3 or 4-part one. But would you agree with that assertion as part one? And also, in your view, what is the best way to enhance usability, and will that require changes to policy?
Well, thank you, Peter, and thanks to Brookings for having us. So I would substantially agree with that comment. I think all of us can make progress towards our goals, but certainly high usability is critical to achieving our goals in a more expedited and more effective and efficient way. I think one of the challenges that many providers have is exactly what is usability. And since usability often seems to be in the eyes of the beholder, but the science of it is fairly consistent and understandable, it's important to recognize, as you had mentioned in your comments, that it's really about the notion of being able to use a product for a specified type of user, for a specific goal, in a specific context of use, and then to be able to do that with effectiveness, efficiency, and satisfaction. So if you think about that, and then you think about what providers experience in their day-to-day work, what you find is we're on a journey. And that for some things, it's fairly straightforward based on the patients we care for and across specialties to have usability work well enough. You can tell that because people don't complain about it. They use it to do their work. They see it as the tool they expected it to be, and they're able to proceed. Things like usability, where it's very clear that although usability for things like interoperability can happen, those of us who've been at the front lines trying to get interoperability to happen between systems have found that it's been very difficult, in part because it's hard for many providers to see the information they would be getting to be sufficiently concise and in a form factor that would work for them or to fit their workflows or to function in the way they would expect it to do. There's a significant issue with signal to noise that is part of the usability connection, and that is part of the concern that physicians and other members of their care teams have, that while they're interested in increased interoperability, unless it is also highly useful and usable to them, then they see it, if you will, as a mixed blessing at best, and potentially can distract them from the care of the patient at hand. So I think part of what we were talking about with our ability to move forward with all the goals that we have is physicians and other health professionals are very much information managers. At the very end of all that, we spend the 80% that is doing healthcare. But the 99% of that is taking and using information to make the best decisions. And the metaphor that I sometimes use with providers is they're looking for a concierge. They're looking for somebody or something who can serve up, anticipate, deliver more than they were expecting in terms of information, decision support, and other tools to accomplish the care that they're looking for. And so without that, it becomes much harder to do this. And much as was the case in paper, they have to rely on memory, they have to rely on what they saw somewhere else, or they have to rely on someone else to do extra work to help make sure that they've delivered all the care that they need to, let alone to do it in teams across time and across geography. So with that, are there some policy issues that could help with this? I would say there certainly are. In my role in meaningful use and advocacy for physicians, one of the interesting things that happened in the transition between stage 1 and stage 2 was this notion that CMS and ONC were starting to look carefully at usability, and a hope and a prospect, if you will, that some kinds of actual aspects of standardization and certification would happen to help with that process. AMIA has come out with some statements on what are some of the criteria of usability. So has HIMSS, so have other organizations, and the AMA has talked about some of the priorities for usability. So what I think we need to do is to figure out a way to help test, certify, and at least give some kind of a process where physicians, much like they did with certified EHR technology, can now have greater confidence that the tool for their specialty will also be usable so they can accomplish the tasks that we're asking of them.
Great. Thank you very much, Mike. Let's move on now to Mark Siegel. So Mark, if I could stay on the topic of, a broad topic of usability for a moment, and to also point out, as Mike continues to remind me, and I obviously forget each time, usability includes usefulness. I often separate them. I want to stretch that a bit further to challenge a comment that Mike just made, but also to tee into perhaps what you might experience as challenging working for a vendor. The statement that all physicians are information managers, I would suggest that some more so than others, and in fact, those of us such as Mike and myself who are internists and manage a lot of information might find that something that helps us to see much more information is useful, where others in other specialties might not find that the case. So from your perspective, Mark, and thinking about specific technology capabilities to enable better care, have current policies led EHR vendors to produce sufficiently adaptable and consistently usable/useful software? Is staying on the current path of federal policy the most effective way to progress towards optimal health IT design and use? Should meaningful use be amended, altered, or replaced?
Big question, Peter. So something that I've spent a lot of time thinking about in one of my roles with the EHR Association, we've actually been talking extensively with the AMA and the American College of Physicians collaboratively on usability issues as they interrelate with meaningful use, but broader. One of the things I've kind of concluded, and GE has a very wide portfolio of health IT, including, but certainly not limited to EHRs, is it's no accident that the segment of health IT that's really had the greatest focus and sort of publicized complaints around usability is the one that's become the most highly regulated. I think that is absolutely no accident. As I think we've seen what has happened, there's aspects of usability that relate to the product. There's aspects of usability that relate to what one needs to do with the product. And Peter, you talked earlier about the focus on process measures in meaningful use. And one of the things that occurs is process measures imply measurement. And so we have, and really our customers, but we've had to engineer as well, we have to make sure that not only do we provide CPOE or patient education where materials are quote unquote suggested by the EHR, but that we can measure what people are doing in terms of their meaningful use objectives. And I think what we've seen is that not only have the requirements around certification directly and indirectly, along with the requirements in terms of what's supported for meaningful use, they've really affected the way the products are put together. They, in some cases, and I think you mentioned this, Peter, have constrained workflows to those that can be measured because our customers need to have them measured confidently for meaningful use. We've had an uptick in audits, pre- and post-payment audits, and again, that really shifts the nature of the program from, sort of a focus on incentives to adopt and meaningfully use EHR. So I think what we've seen is a combination of where the products themselves have been affected over time by aspects of the certification process. And then I frankly think more profoundly is the sort of perceived requirements on providers about how they have to use them. I love my smartphone. If my employer was telling me exactly how I had to use it, I probably wouldn't love it so much. So from a policy standpoint, where this really leads me, and it's sort of ironic in a session focused on policy, is in general, I think we need less policy. I think there are areas where we can improve policy. I think most of that, frankly, can happen at the regulatory sphere, thinking about meaningful use as opposed to needing fundamental changes in the legislation. But in many respects, I think what we need is a respite from policy. We need to have really the space for providers and vendors to respond to all the changes that you and Larry were talking about earlier. Nobody knows exactly what is the right approach to population health management, for example. And we need to let the normal market forces that have worked in so many other areas of health IT help us work with our customers to determine what are the best approaches. So I'll leave it there for now.
Great. Thanks, Mark. And one comment that I'll make on something Mark said that I think is important and something I've written on in the past is the one about physicians complaining about usability, mostly where the workflows are regulated ones. I think it's important as we think about this to remember that some of the complaints may come from physicians being requested to do things they never did before, and not so much on the EHR. So we need to be careful as we think about that we are indeed doing a little bit of a bait and switch, which I think is appropriate as we bring in health IT to try and build in safety and quality into what we offer. So it certainly adds complexity, further complexity to what you suggested. Switching off that topic for now, we're going to go to John Blair. John, for a variety of reasons, the past decade has seen an increasing number of doctors leaving private practice and being employed by hospital networks. One such benefit, with all providers on the same EHR, interoperability is less of a problem. In fact, in some cases, it just goes away. However, what you have done with Taconic IPA has provided the value of integration without the need to give up private practice, what we used to refer to as virtual integration. Are the current policies on interoperability working for Taconic? What works well? What could be improved? Are additional policies needed?
Thanks, Peter. And again, thanks for inviting me here. A couple things. I'll answer that, but I want to come back to the question about value of the actual system. I would say the policies, it's too early to say. I think we're just starting to touch on interoperability. If you look at meaningful use, the MU1 was about getting these systems out. If I had a criticism about it, it would not be for being overly prescriptive. I'd say that we were greatly under-resourced on the implementation, training, and support that was needed for these systems. When we look in the Hudson Valley, I'd say we have about a third of providers that are using these systems well, getting great results. I was just at the Comprehensive Primary Care Initiative meeting at CMS the last 2 days, and you can start to see we're actually starting to show net savings in the Hudson Valley with that program. So we certainly see provider organizations that are doing very well. Some are really struggling, but we have about a third in the middle that need more help, particularly the smaller groups, and that's a resource issue. It's not the systems that are being deployed out there. But when it comes to interoperability, Stage 2 starts to address that because of some of the delays in attestation. Large numbers, particularly in the ambulatory space, have not started to really implement and utilize those systems. Where we're seeing providers using them, and maybe 20% are now starting to use these systems for interoperability, sending and receiving information, particularly around referrals and consults and discharges. There is tremendous interest from the providers. Now, these systems, I'm not going to say these systems are perfect, they're imperfect. It's very early days on this kind of rollout, but the providers, when you implement them well, get the workarounds done and really do role-based workflow, training and utilization, they are enthusiastic about it, but it takes that effort. So again, we're early. I would say the policy, it's way too early to say there's an issue with it. We are able in our region to utilize what's there, and we're achieving the results that we want to achieve. With regard to your first question about the value, getting the value out of these systems, for us the value comes from how you practice medicine, how the provider practices medicine, how the provider organization does, and how the community does. These are tools, and again, we're rolling this out across the country. It's, again, very early days for this kind of real change, and the tools are clearly, at least for us, working. There was a recent, we spent 5 years looking at 3 groups: paper-based providers, providers on electronic health records, and providers that have done transformation to advanced primary care, patient-centered medical home. We saw no difference in quality and cost between paper and EHR, but once they went to advanced primary care, there were significant improvements in cost and quality, but I can tell you that they could not have done that without these systems that are being deployed today.
Great, and thank you, John. And in keeping what I've been doing, a few comments on what you've said that I think are worth drawing out a bit more. The point about being under-resourced, if I may amend that, also under-resourced and under-trained. Mike Zarukian has written extensively also on the necessity of training to elevate usability, and I've noticed within my own health system that when I moved away from being the primary instructor of how to use a system and delegated that to others, I got a lot of complaints about how unusable the system was, and then found out that they have been taught to do 5 or 6 added steps that were completely unnecessary. So certainly great points, and I would also say that your point about health IT is a tool, it's enabling infrastructure, and how it's coupled with care, and particularly care that is heavily reliant on information, I think will really allow it to bloom. Let's move on now to Mark Bannett. Mark, most of your work has been on supporting providers and small practices to develop appropriate infrastructure for improving care. 2 questions for you as well, and you're welcome to make that 3 or 4 if you'd like. First, you have been generally supportive of meaningful use, but have also said that more flexibility is needed to allow for pathways for success, as well as more opportunities for innovation. So, first part of the question, can you describe what you mean by flexibility and innovation, perhaps give some examples? And second, do you feel that this is possible to do within existing policy, or is some modification necessary?
Thanks. So let me just start by saying, as a person who's worked primarily with small practices in the Regional Extension Center activity, in the Regional Extension Center program, my view is that for these practices, that flexibility is the critical feature. And so what I mean by flexibility, I'll start there and then maybe talk about innovation. I think flexibility both in the timelines, either in terms of the length of time you have to be able to demonstrate use for to be able to move forward to the next stage, or flexibility in the when you start. And so I think CMS has attempted to offer that kind of flexibility, but we need still further for some of these small practices. As an example of the challenge, I'd probably use a patient portal as a requirement under the new the current stage. I think there is it's a tremendously difficult thing for a small practice to implement a patient portal, and yet it's a really important thing if you understand the vision of the role of the patient in helping to manage their own care. And yet, in today's world, the use case for that is virtually non-existent. Very few patients really take advantage of it. The incentives aren't aligned in that way. That vision is a long ways off. And where a larger organization might be able to implement that feature and live with a fairly small number of users, for a small practice, especially in communities where there aren't alternative solutions to that, it really makes it difficult. In addition to timeliness, I think sort of number of measures. I think, again, CMS has tried to manage to this, but not all systems can produce automatically all of the measures in today's world. And so there's a lot of manual work required, and small practices are really buried by that manual work, the workarounds we get to produce the necessary outcomes. So when I speak to innovation, I'd probably say, for me, the key to innovation is to sort of set our goals on the right focus. And you alluded to this earlier. Right now, we're trying to manage to processes, and managing to processes, I think, is the opposite of an innovation environment. If we could manage to the outcome, what do we want to achieve from our large investment in health information technology, then I think we'd have an environment that is much more conducive to innovation. I'm not an HIT person, I'm a policy person, and I understand the challenge that presents for us, because in some sense we're living in a chicken or an egg world where we need the processes in order to build the infrastructure to allow systems to be able to thrive under new payment models. And right now it's very difficult to make that transition. So right now I think there's a good bet that absent the health information technology systems and support infrastructure being built, if we transition to advanced primary care, or we transition to ACO, or we transition to global fee in some fashion, many providers would fail under that model. So we have a real need to solve that problem. And for us, I think that's the key, is we have to acknowledge that at the same time we need that infrastructure built, we also have to understand that by continuing to focus on so many process measures, we undermine innovation along the way.
Thank you. And again, I'll keep with my strategy here of offering a comment. As we look about statistics on patients and portal use and patient engagement with their data, we really see conflicting results. And one observation I would offer is that many of my patients, either because I gave it to them or they figured it out, it's not that hard to figure out, have my email, and certainly use it to ask questions, the kind of questions I would hope they would be sending to the patient portal. So I think this issue of usability, user-centered design for patients, actually comes into that as well for patients. And it's hard for me to blame patients when they email me with what are my results, I'd like to renew this, if the processes that we put in place are difficult for them to use as well. So I think time will tell really about how much patients will use that. We have about 3 minutes left before we go to questions from the audience. So I'm going to end with a wrap-up question that you're all welcome to take a stab at. Mike, did you have a comment?
I was wondering if we could comment a little bit on...
Please, go ahead.
So there's actually a couple of things using the chicken and egg, I'd like to add the law of the farm metaphor here if I can.
Sure.
So, and everybody understands it, right? You plant, you water, you give sunlight, you weed. We have a garden we're trying to grow, and that garden was based on some federal strategic IT plans that I think were sound and that I've certainly tried to promulgate. We need to capture data, we need to share it, we need to use it well to transform care. That vision is no less true than it was before. Nevertheless, in the spring, you can't harvest any fruit from that. It's impossible. If you start to expect it in midsummer when there's a little bit of greenish fruit, you will also kill the fruit and kill the plant. So part of the tension that we're dealing with here is the reality that some of what we would like, we can probably get. Some of what we would like is beyond a realistic capacity to expect it yet. So I think both in policy and incentive programs and payment models, we have to understand the law of the farm to ask and answer the question, what can we expect reasonably now? And then how can we make it as easy as possible for people to do this? So as much as a primary care physician, I see the need to put data in certain ways in order to improve care. I don't have to do it all myself. I do have additional staff that supports it. I also know that if I or my colleagues don't do this, then it will be very hard to find the information that we need to improve care. For me, the Meaningful Use program, and for the folks that I've worked with, is it's made health IT go from a nice to have and a small penetration to a let's all pull together and do this. And oh, by the way, if we have to be willing to strive, then what are our goals for patient care quality, safety, efficiency, effectiveness? Oh, by the way, a little bit of incentive payment that will help us during this transition. But over time, it's part of what we see the future of healthcare to be.
I don't want to wreck your last question, but
No, that's all right.
So back on the PHR.
The last question, by the way, was how can I get the panel to?
So on the example of the PHR in a small practice, I think that's very common. I'll just give one for instance. About a week ago, somebody was up from ONC visiting our area. We just took them to a practice for their monthly advanced primary or their monthly meeting to review their metrics, look at their readmissions, et cetera, which all of our advanced primary care practices do. And it's a 2-doctor practice. They are on an EHR we have about a dozen, I would say, that are of a dozen that covers most of the practices. And we hear from the system's terrible, you can't use it, to very, very good usage. And it always comes back to implementation. This group did all of the things we wanted them to do. They had implemented their PHR, 2-doc practice, same system as many that say they can't get any PHR usage. Over 80% of their patients are signed up and using the PHR, and when they got to reviewing their diabetics, the person pointed out when asked from somebody from ONC how you interact and patient engagement, a third of the diabetics are using their PHR for that interaction with the office. So it's not the system, it's not the practice size, it's the implementation, training, support. And in terms of process, you can over-engineer process, but for many of these groups that are trying to figure this out, some process measures we still believe are important.
Comments, because I'll ask one last, I hate to say I'm going to do the Washington talk show thing of final word and keep it short, but I think that's what we're down to now, 2 minutes, and it might take me 2 minutes to ask the question. Basically, here is the question. I want you to consider two very different scenarios. Scenario one is the one that I'm hearing from many of you, which is patience. Let's let things play themselves out. This, of course, is a time when people will be grumbling. This is not the time when people will be seeing their fields ripe with crops. So assume no changes to MU, no new policies. Stage 3 of MU emerges about the same time as more tangible value-based payment methodology, staying the course. Scenario 2, however it happens, maybe the same way that we have a nice day today and it's going to snow tomorrow, magic happens. Let's say MU process measures disappear. ONC's role is now much more tightly focused on interoperability and infrastructure to support value-based care. Value-based payment becomes more tangible as MU is fading away. What would be the most challenging about each scenario? Which scenario would best support value-based care? And try one relatively short sentence for each one. Challenging, which system would best support? Let's start with you, Mark.
So I favor the first scenario. I'll say that up front, and I think the reason I do that is I think the challenge with the second scenario is, like most things in the American healthcare system, healthcare is very resilient in a really negative way, and so it's really easy for our healthcare system to fall back to the status quo. And my primary fear is if we don't keep pushing, that we're just going to go back to the old world and we're not going to actually get to that end stage we're looking for.
Yeah, I would echo that as a person who's in the field trying to help physicians and other staff see what it is they need to do. The content of the meaningful use regulations have helped, if you will, frame that issue, allow me to provide the rationale, the justification, talk about how to make it easier to do it right and harder to do it wrong, as opposed to if all of those process measures went away, having to help convince my colleagues why information needs to be in the system in a certain way or the tool used in a certain way is a much tougher climb, and I fully agree that we would backslide if we did not have some kind of guardrails to help keep people on a reasonable path, while appreciating Mark's very important comment about making sure that we're not overdoing it and that we're not, as a result, ending up with unintended consequences.
So I'd sort of split the difference between your two scenarios. I think that if you actually go back and look at the initial high-tech legislation, it's very broad. You know, it focused on meaningful use, if I'm remembering this right, was e-prescribing, quality measurement, and interoperability. And it seems to me that we need a substantially different, more focused regulatory approach going forward around stage 3 and associated certification. I think not only should it be focused, the area of focus should be primarily around interoperability, as well as aligned quality measures, because as we've been hearing, quality measures are going to be integral to the various types of value-based payment. I think that the patient's point is very important. If you look at what was put in place in stage 1 and stage 2, both in terms of requirements, some of what Mike was talking about, and in terms of what's in the EHRs around interoperability, very robust functionality. Moving to a single coded approach for problems, a standardized approach for sending clinical information. What we really need to do, and I think that the farm metaphor is great, is enable both vendors and providers to really digest what's happened in the last 2 years and to be able to do that in a structured, predictable way while we're having more focus and also having critically, and I think this relates to the last point, what we've heard about training. We need enough time for us for developers to develop the product, to do it in a way that's interactive with our customers, and then enough time for our customers to implement and train in ways that they feel comfortable.
So being out of time, I'll be quick. So I would go to what Mark just said. I would do something between. Although not perfect, many good things have happened with meaningful use. And so I would iterate. I would not pull it out and replace. First of all, that's the disruption. I don't know what that would do. And how do you know that what you replace it with is going to work? So I think that you iterate. I think you narrow the focus. I think that the interoperability and quality are where you push that. And that's how I would handle it.
Thank you. So I'll make a last comment before we go to questions from the audience. I want to thank the panelists for braving the weather and coming to DC, and also for your remarks. From my opinion, I certainly think there's value in all that you've said and looking at both sides. I would offer the observation that being overly cynical, as those of us who have been involved in implementations tend to get, might not be being fair to our colleagues. I'll just finish with this example. In our health system, one of my battles was fighting with doctors to provide a clinical summary to patients at the end of each visit, and it took forever to get them to do it. And during one of my endless meetings with our chief medical officer about how are we going to comply with this 50% threshold, he looked at me and said, "We're not complying with a 50% threshold. This is now what we would consider necessary for good patient care. I don't want you to work to get 50%. I want to know why it's not being done 100% of the time." It's in the DNA. So in fact, I think we need to be sensitive to when that happens, but obviously be vigilant for when things slide back. So let's open this up now to questions from the audience. And we have someone going around with mics. And if you would please briefly introduce yourself and ask your question, and feel free to direct it to a particular panelist or to the panel in general. Thank you.
Ken Dillon, Ciencia Press, to the entire panel. Two suggestions. I appreciate your comments. The first is for training of those smaller organizations which are not yet up to snuff, have you tried peer training? In other words, to get the top performing people somehow to incentivize them to open up and explain things to the ones who are still struggling. And the second one is in regard to the question of, let me see what I have here on it. I apologize. Well, let's try the first one first.
I'll take a stab at that. So I mentioned we're part of CPC, and I probably, for those that don't know what that is, it's the Comprehensive Primary Care Initiative out of the Innovation Center. There's 7 regions in the country. One aspect of the technical assistance that we do and that they want done generally across all regions is peer-to-peer learning. We have tried that. We're just finishing the second year of this, and there are several peers that we use as examples, but the difficulty is getting those providers to have the time. You certainly can't get them on site. To get a provider to leave for a whole day, their practice, it's just very difficult. So we've tried webinars, mild success with that, but I think that the peer-to-peer is a great idea. The problem is getting the highly productive, successful peer to have the time to get out to the others.
I'd just add to that, I think the peer-to-peer learning is a core part of our strategy in the Regional Extension Center work and in the QIO program as well. And I think the key is figuring out a solution that doesn't get the physician out of their office all day. You just can't do it. They have too much to do. It's very small.
And as a medical educator, the other thing I would just add is that it's actually a double-edged sword to use peers. So people have different learning styles. Leverage those. Use peers when it makes sense. Make sure your peers are standardized, because otherwise they'll be teaching 17 different workarounds for an approach that should be happening one way.
Yeah, I mean, training is absolutely critical, and nowadays, from a technology standpoint, there are all sorts of ways to do distance learning. So we do a lot of webinars. We post, videos and PDFs. We have an active user group, and they use their message board to help each other peer-to-peer. And so I think what's critical with so much education, as someone said, there's all sorts of different styles of learning. It's doing multiple ways of instruction, and also doing it in ways that respect the busy time that people have. So have people basically being able to learn and train when it's convenient for them and not just when it's scheduled.
Thank you. We have a lot of people asking questions. We've got about 3 minutes, so whoever gets given a microphone goes next. I apologize for that.
Adrian Gropper, Patient Privacy Rights. Very little of medicine is secret. The tools of the physician tend to be open for peer review and modification in terms of workflow and whatnot at the edge. As we consider the role of regulation and the importance of health IT as a physician tool, where do we draw the line on the tools themselves not being peer reviewable or modifiable?
So I'll just jump in from our perspective. I think this is an issue that maybe isn't standardized, and I wouldn't want it to be perhaps nationally, but as we look at the safety of health IT, if we look at our own organizational readiness, our validation sessions, et cetera, there's all sorts of peer review, if you will, both of how a system's designed and then feedback reports on how people are using it and what consequences those have. So if there's ever a serious safety event, if there's ever a risk situation, we can then go back and look at how the system was used and whether the system needs to be reconfigured to improve that while maintaining confidentiality.
Because we only have 1 minute left, I know others may answer that, but let's go to our last question.
Bob Lenahan, working with Montgomery County Health and Human Services. And to elaborate a little bit more, the interoperability of healthcare data moving towards exchanges, so the medical record and who owns it, and privacy issues associated with that we're struggling not only in the EHR piece, but also safety net services that we're extending to. Any comments?
Well, so I'll just say at the meaningful use work group level and elsewhere, there is absolutely this issue of looking at how do you parse out, if you will, the data release kinds of rights that patients have, and how do you build into the technology the ability for patients to restrict the release of information around things that tend to be sensitive, HIV, reproductive health, mental health, et cetera, et cetera. So those are definitely part of the process and the plan. The key issue is, again, how do we make it work and how do we make it usable?
Do we have any questions from our online audience online? No? Okay. Well, I think we are out of time. So I want to thank all of you for such a great discussion of where we are now with health IT and how we can progress further to better support high-value care. And now on to our next panel. Thank you all.